alaikum, Dr. Sajjad. How are you?
Welcome salam, sir. Yes, sir, I'm fine.
Yes, good. So, are you ready for our today's session?
Yes, sir.
Okay. So, today, inshallah, we will be discussing two important cases, one of clinical consultation and one of clinical communication. And these cases have been chosen quite carefully to teach you the approach, not only just two cases, rather multiple other associated cases, so that you should learn something and you should get maximum benefit out of a single session. So, let me share the screen for you. I think we should be doing first our clinical consultation. Okay,
Okay, sir.
my voice is clear and loud.
Yes, sir.
Good. So we are starting. Bismillahirrahmanirrahim. And we are starting from Dr. Sajjad, and I am sharing my screen. And Dr. Sajjad, if you are able to see my screen, please do let me know.
Yes, sir.
Okay. So are you able to read it clearly? Is it my screen is clear?
Clear, sir.
Okay, Dr. Sajjad, I will be giving you total 15 minutes for clinical consultation, and I will prompt you at 13 minutes. You are supposed to take the patient's medical history, do the examination, address his concerns, and try to explain management plan to the patient. Okay.
Okay, sir.
And before that, I am giving you almost 3 to 4 minutes to prepare this case very well. Here we go. Dr. Sajjad, once you're ready,
Yes,
please
sir.
do let me know.
Okay, sir, we can start.
Okay, so just a second, please. Let me set the timer for you. I'm giving you timer, total 15 minutes for this consultation, according to RCP protocol, and your time starts now.
Hello, I'm Dr. Rahman, one of the PACES candidates today here. May I confirm that I'm talking with Mr. Arsalan Khan and 19 years age?
Yeah, I am the same.
Okay, so today I'm here to discuss about your health condition as well as I will examine you. Is it all right?
Yeah, fully all right with me.
During our conversation, I will take some notes. It will be highly confidential. May I know what bring you here today?
I am having some problem with my blood pressure, and I believe that it is really causing trouble to me.
Okay, may I know that for how long you are suffering from this problem?
Recently. Actually, previously, my hypertension was in control, but about for the last 1 year, it is not in control.
Okay, may I know that is it progressively increasing day by day? I mean,
It
your
is
symptom.
getting worse.
Okay, may I know that what kind of problem you are suffering from this hypertension?
Nothing, but just one thing when I am checking my blood pressure, despite of taking medications, it is not in control.
Right. Okay. May I know that what kind of medication you are taking?
I am taking lisinopril about 10 milligrams, and recently my GP has added I am immigrant to United Kingdom recently, and I am bringing amlodipine also 5 milligrams.
Right. Are you compliant with this medication? May I know?
I am a good patient.
Okay. You are suffering from hypertension for the last 1 year. Are you contact with your GP or your doctor?
I'm sorry, but I need to confess that back in my country, I was not in regular follow-up of the doctors and I was totally ignoring my health.
Okay. Okay. So may I know that do you have any headache?
Not as such.
Okay.
Sometimes only. It is,
Some
you can say, coming and going, but not continuous.
no, not continue. Okay. May I know that do you have any vision problem?
Yes, I am having a vision problem also.
Okay. For how long you are suffering from vision problem?
I am having vision problem, if I am not wrong, for about last 3 to 4 years.
Right. Did you contact with your GP for this problem?
Yeah, back in my country, I was in touch, but no diagnosis had been made then.
Right. Okay. Can you describe me more about your vision? Right. Is it blurring of vision or complete loss of vision?
It is like a blurring of the vision.
Okay. I mean that is it a problem in the seeing any side? I mean, ups and downs in the side?
No, it
No.
is
Okay.
just
Do
in my
you
complete
do you see
eye.
the
Yeah, yeah.
okay? Okay. Do you see the double?
No,
I mean, do you see any object double?
no.
No double. Okay. Okay. May I know that any long-term medical condition I must aware of
At least
other than
nobody bothered to diagnose me previously.
okay, I'm really sorry for that. You are suffering from this problem. Okay. May I know that do you have any weight changes? May I know?
Yes, I believe that I have lost some weight and it is progressively getting decreased over about a year. I have lost about, I think, 3 or 4 kilograms of weight.
Okay. Is it intentional?
Totally unintentional.
Okay. May I know what about your appetite?
Appetite is normal.
Appetite is normal. Okay. So may I know that do you have any weather preferences?
No, I don't have any weather preferences.
Okay. Okay. So may I know that do you have any sweating?
Uh, no sweating at all. Sorry. It is
Yeah.
happening. It is happening that sometime I am sweating also.
Right. Okay. Do you have any racing and pacing of the heart?
Yeah, you are very right. It is also happening that my heart is pounding.
Okay. For how long this problem?
It is also there for about last, I think, couple of months.
Okay. So may I know that is it regular or irregular? Can you tapping it for me?
Patient is tapping on the table regularly for you.
Okay, right. Is it comes and goes? I mean, sometimes it's present, sometimes goes off.
I am astonished. You are a good doctor. It is happening like the same way that it is coming and going.
Okay. What about your mood? May I know? Are you anxious recently?
Yeah, I feel that I am more anxious.
Okay, okay. So may I know that what about your bowel work?
What do you want to ask in the bowel works?
I mean that any kind of loose motion or tight bowel?
No,
No tight bowel. Okay, okay. So may I know that do you have any chest pain?
uh, no.
No chest pain. Okay, okay. So may I know that what about your water work? May I know?
What do you want to ask in waterworks?
I mean that any change in the amount and color?
No,
Okay, okay. Any prothiness?
no,
Any high color?
no.
Okay. Uh, may I know that do you have any lump in your neck?
Lump in my neck? No.
No lump in the neck. Okay, okay. So may I know that do you have any, I mean that more thrust recently?
You mean to say I'm more thirsty nowadays? No, no, nothing
Yes.
like that.
Okay, okay, okay. So, okay, okay. So may I know that uh, any, I mean that any, is this disease run in your family?
No.
No. Any disease run in your family?
Yes. My father, he has been diagnosed as the case of cancer in the brain.
Okay.
My
For
brother,
how?
he is having some hearing problem. And
Okay.
my mother, she has been diagnosed as the case of blood pressure, but they were attributing it to the age.
Okay. Okay. So may I know that do you have any lumps and bumps in anywhere?
Yeah, I believe that I am having some lumps and bumps.
Can you show me your rash or lumps and bumps?
Yeah, you can see my lumps and bumps.
Okay. 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 Can in which area this lumps and bumps is present?
And they are on my back, and I can feel them.
Okay, okay. You can feel that. Okay. For how long this problem?
Oh, yeah, this is actually not causing any issue to me, but they are there for a couple of years.
Okay, okay. Can you show the another any rash in anywhere?
No rash.
No rash. Okay, okay. So, but do you have any fits? I mean that any jerky movement of a limb?
No,
Okay, okay. So, do you have any hearing problem?
no.
No hearing problem. Okay, okay. So, okay. But do you have any loss of consciousness?
Oh, it never happened.
Okay. So may I know that any weakness in any in your limb?
No.
No weakness in your limb. Okay. Okay. So, any abnormal sensation?
Yes, I feel that my legs are getting numb.
Okay. For how long this problem?
This is happening, if I am not wrong, for about last 1 year.
1 year. Okay. Okay. So, okay, I'm really sorry for that. Can I examine the patient?
For sure, you can.
Okay. First of all, General, I want to see the vital chart. Is it like outside?
Same like outside.
Okay. Any postural drop of blood pressure?
So you are offering the examiner or orthostatic hypotension checking. Examiner is telling you that there is no orthostatic hypotension present.
Okay. Then I want to go for the complete full the skin survey. Is there any lumps and bumps and rash in anywhere?
Exactly where do you want to see? Because you have to expose the patient.
Okay. So first of all, I want to check the back. Is there any rash and lumps and bumps?
So I am sharing with you the back. This is the back. One thing you are finding over there. Second
Okay.
finding on the back. This is the back finding.
Okay. Okay. Can I want to see the patient face? But is there
So
any
you want
rash?
to see the patient face, and I have already shared the patient face. There is no other finding there.
Okay. Okay. So uh, uh, I want to examine the patient's leg. Is there any weakness, any kind of abnormal sensation?
How you are checking the patient leg?
Yes. First of all, I will go for the motor examination, then the sensory examination.
So you are checking for inspection. Initially, you are doing inspection for the legs. On inspection, there is nothing obvious present. Then you are going for power checking. Bilaterally, of course, it will kill some time in the real exam. So I am mimicking it like a real exam. So we are wasting time about 15 to 20 seconds out there. Power in the legs is normal, equal bilaterally. Now you are going for the fine touch. You are instructing the patient that I am touching your forehead. You will feel this sensation like that. And you should be closing your eyes, and I will be touching both legs, both lower limbs. And you have to tell me exactly whether you are feeling it like your forehead or not. So you are checking bilaterally. Sensations are reduced, and you are left with 1 minute and 30 seconds.
I want to do the fundoscopy of this patient. Uh, but-
Okay, you are going for the fundoscopic examination,
yes, sir.
turning off the light, checking for the red reflex. Essentially, fundoscopic images in the bilateral both eyes are totally normal.
Okay. May I know that what's your concern?
And while you were doing fundoscopy and you were coming closer to the patient eye with your fundoscope, you are seeing this finding.
Okay. Okay.
My concern is, do you think that my condition is curable?
I'm happy to tell you that it's not curable, but the symptom of this problem is manageable. Do
Do
you have
you
any other
think
concern?
that this condition is running in the family?
Yes, I'm happy to tell you that it runs in the family.
Is it possible that this condition is not running in the family and I am getting it alone?
But it's highly unlikely, actually.
Am I at the risk of any cancer?
Yes, you are also
How
risk
is
of
my
cancer.
life expectancy?
Okay, I'm afraid to tell you that is really some short of the
Time
normal.
is up. Please summarize your case.
Okay, Mr. Arsalan Khan, 19 years age, come to this hospital with a high blood pressure, and he was not contacted with GP, and he was not diagnosed previously. Patient also complained of some sort of vision problem, and as well as he complained about the sweating and occasional sweating and palpitation, and on examination of this patient, I have found that there is multiple rash and lumps and bumps in a different site, and as well as on examination the vitals, I found that patient blood pressure is high, and there is peripheral neuropathy present, and then the fundoscopy and the examination of the eye, I found that there is a leech nodule. Leech nodule is present, and and that's it, I think.
What can be the cause of hypertension in this patient?
Okay, your is hypertension is due to pheochromocytoma, and which is related to a genetic condition. We call it tuberous sclerosis.
So you are saying that the diagnosis out there is a pheochromocytoma associated with a tuberous sclerosis, right?
Yes, sir.
Okay. Any other cause of hypertension you are considering in this patient except pheochromocytoma?
Sir, I have to exclude, sir. This can be glomerular disease, as because patient is young, and another thing is ADPKD, also a possibility of this patient.
Are you examining the kidney?
I have to, sir.
Okay. What are the features of tuberous sclerosis you are getting in this patient?
Okay, sir. I have found that there is capsulated spot and
If this is the
adenoma.
case of tuberous sclerosis, are you checking for the high arched palate?
No, sir, I have to.
Any chagrin patches you're finding out there?
No, sir.
What are the associations of tuberous sclerosis?
Okay, sir.
Do you think that pheochromocytoma is associated with tuberous sclerosis?
Sir, distance possibility, another it's neurofibromatosis, I think, possibility.
So is this a case of neurofibromatosis or tuberous sclerosis?
Sir,
Okay, if
neurofibromatosis.
this is a case of neurofibromatosis, then what is the cause of hypertension in this patient?
Sir, one is pheochromocytoma, another is that renal artery stenosis is the possibility, and another is essential hypertension.
Okay. So what is your plan to how you will thoroughly investigate this patient?
Okay, sir. First of all, I will investigate this patient by doing the renal function test, and then the ultrasound of the whole abdomen, and then the
Okay,
ECG,
what you are suspecting and what you want to see in ultrasonography of the patient?
Okay, ultrasonography. I will expect any kind of ADPKD is present or not, as well as the renal artery stenosis is present or not. by doing
Okay,
the
and
deepest level.
what make you think that might be there is ADPKD in this patient?
No, sir. That's like.
Okay,
And then I will go for the risk factor other, that is lipid profile, as well as the blood sugar level, and then the electrolyte level. Is there any kind of hypokalemia is present or not?
okay,
And then,
how hyperkalemia is linked with this case and what it will show us?
so to exclude the other differentials actually,
Like what?
sir, Conn's syndrome, like,
Do you think that this is a case of Conn syndrome?
no, sir, no, just
Okay,
to exclude that, and the genetic testing, I think, finally.
okay, what do you want to see in genetic testing?
Sir, any kind of neurofibromatosis gene is present or not?
Okay, which gene is involved?
Neurofibromatosis, one gene, I think, if I'm not wrong.
Okay, is there any gene which is involved? Any other gene, sorry.
I'm not sure, sir.
Okay. So is it a tumor suppressor gene or which sort of gene it is?
I'm not sure, sir.
Okay. Any other investigations you want to offer for this patient or any plan of investigations you are, thinking to offer on frequent, frequent intervals?
For pheochromocytoma, sir, I'll go for the urinary metanephrine and as well as the catecholamine level, and
Hmm.
that's it, sir, I think.
Any other management options you want to consider?
Okay, sir. For general management and specific management, general management, patient education, counseling, and explanation of this disease condition,
Hmm.
and then I will advise patient about the lifestyle modification, and then I will involve the genetic counselor in this regard and
Hmm.
refer to the genetic counselor team, and then
Okay, this
specific.
patient is denying that I am having no family member with this condition. Is it possible that it can happen?
Uh, I think, sir, yes, it can be possible. There might be skip generation, I think, possible, I think.
Okay, go ahead, please.
And then specific management for hypertension control, and I will involve the multidisciplinary team, including the cardiologist, and as well as the endocrinologist, and as well as the occupational health physician and dietitian.
Hmm.
And uh, then I will go for the alpha blocker first, and then for beta blocker. And for pheochromocytoma, and I will go for the when blood pressure is controlled, then I go for the surgery.
Okay,
And if it is related to neurofibromatosis, and then for genetic counseling for this patient for neurofibromatosis, and then if any kind of disfigurement, I mean that then I'll refer to skin doctor and cancer doctor whether any kind of surgical procedure possible or not.
which sort of surgical procedure you want to offer for this patient?
If any kind of malignant transformation is possibility, then there might be surgical
Okay, can
option
can
for
you please comment on the face of the patient?
uh, it's like exophthalmos.
Okay, what can be the reason?
Sir, is, uh,
Okay, let's discuss this case. By the way, nice effort, and it was a complex case, a difficult case, and this is a level 3 case, and you have tried your level best to, explore the diagnosis, and you have tried your level best to be on the ground on the feet, and I can appreciate your confidence. So now let's see exactly what we are missing and how to reach the diagnosis. Dr. Sajad, are you with me? My voice is clear
Yes, sir.
loud to you.
Yes, sir.
Okay,
I'm
first let's first have a grip on the case. Main thing is that whether we are dealing with pheochromocytoma or not, whether this is something called fibrodysplasia or not, whether this is tuberous sclerosis or NF1 or NF2, what we are dealing with. Okay, so this patient is a young male, and this patient presented to us first time, and we are not knowing any background history, and he is not telling us. It means that it is hidden, or they are deliberately hiding it. Dr. Sajad, my voice is clear loud to you.
clear, sir.
Okay, now I am focusing on this scenario. Please pay attention, because I am teaching you people how to reach the diagnosis and how to be very sure that this is the diagnosis, and I need to catch it from the neck. Because if I am not gripping on the diagnosis, my concerns, the way I am answering the concerns, will be loose. Ultimately, my investigation plan, my management plan will be in the loops. So let's discuss first exactly how to reach the diagnosis. This is the case which will be given to you. You are sitting outside and you are reading something that the patient is a young male. Important thing is young male. Recent immigrant to United Kingdom and had uncontrolled hypertension. Now, two things which are really important for me over here is the age and uncontrolled hypertension. He is having a long-standing history of decreased vision, and I'm seeing that the pulse is tachycardic and the BP is on the higher limits, and ESR slightly higher side, on the higher side. So this is the data provided to me, and I am sitting outside and I am making my differential list. Now, multiple things are coming in my mind. If I am talking about secondary hypertension, Cushing will come, acromegaly will come, pheochromocytoma will come, drugs will come, fibrodysplasias will come, means renal artery stenosis will come. Every cause of secondary hypertension should come in my mind right now. Okay?
Okay, sir.
Including Conn syndrome, which you were mentioning. So I am sitting outside and I am thinking about complete spectrum of the causes of uncontrolled hypertension in the young male. Only 19 years, only 19 years, only 19 years. So I am thinking about all the differential diagnosis which can cause uncontrolled hypertension in a young male. With this, I am entering inside the examination hall. And when I am entering in the examination hall, my inspection should be very strong. I should be able to pick each and every finding if I am seeing it. So when you are going inside, you are seeing that there is proptosis. And this proptosis is unilateral. It means that there is something fishy on the one side. Okay.
Okay, sir.
Now, I am starting taking the history, and I am starting the history from uncontrolled hypertension, because this is the burning issue or hot issue. This is the issue with which the patient is presenting to me right now. Yes, I will also explore the decreased vision, but right now the presenting complaint is uncontrolled hypertension. So now how to take the history of uncontrolled hypertension. This is a non-pain symptom, so I will be going with OD para. Onset, it was gradual. Duration, it is happening for about 1 year. Relieving factor, nothing is relieving it. Aggravating factor, nothing is aggravating it. But what about medications? You are taking some medication. Are they affecting you? No. So onset, duration, relieving factor, aggravating factor, progression, P for progression, whether these episodes are getting progressive or not. Last is associated symptoms. Patient with uncontrolled hypertension, young male, and is not getting in control with the multiple medication. You are asking, he's already taking from outside lisinopril and amlodipine. It means that there's something fishy. We need to explore it. So what I will be asking in the associated symptoms, I will be asking first thing, anything, any changes in your appearance. No changes in my appearance. Any changes in your head size, foot size, hand size? Nothing. Any bumping into objects? Nothing. I'm slightly comfortable that I'm not dealing with acromegaly. Going ahead, any bad body aches? Bad body aches, myalgias, which are showing me that this patient is having high, Con syndrome, potassium metabolism dysfunction. So patient is denying it. Let's go ahead towards other causes, that whether you are having any sweating. Yes, I'm having sweating. Any shakiness? Yes, I'm having shakiness. Any headache? Yes, I'm having headache. Any flushes of the face? Yes, I'm having flushing of the face. Now there are two possibilities. Either these all symptoms are coming together, or one by one, or they are not associated. Are you with me?
Yes, sir.
So when you are asking me, I am telling you that I am having episodic headache, episodic tremors, episodic sweating, episodic racing and pacing of heart, flush of the face. So I should be asking exactly whether they all are coming together or not. If they are coming together, it means that there is catecholamine rush. The symptoms of pheochromocytoma. Still, I'm not satisfied. Still, I am thinking about Cushing also. I will be asking about any weakness in your shoulder region, hip region, any striae on the tummy, any bruises. I am bothered about whether he is using any herbal preparations, any medications which can lead to high blood pressures, because I need to exclude all the causes of secondary hypertension. Are you with me?
Yes, sir.
So what I am getting up till now, that this patient is having some eye problem, old story. I am not touching it. Just I am seeing proptosis, but hypertension is uncontrolled with the tremors, with the sweatings, with the headache, with the flushing of the face, and racing and pacing of heart. If you want to confirm, ask a close-ended question. Are you checking your blood pressure at that time to confirm that it is a pheochromocytoma? Still, you are confused with, say, for example, hypoglycemia. It can lead to these symptoms. Say, for example, you are confused with hyperthyroidism. Categorically ask. Any blurring of the vision or low blood sugar levels at that time. Any weather preferences, or you are avoiding hot weather. Clear?
Yes, sir.
So what we are dealing with? We are quite comfortable that we are dealing with pheochromocytoma up till now. So I am always teaching you people that whenever you are dealing with one diagnosis, you should be bothered about its association or complication. We are catching one thing, that we are dealing with pheochromocytoma. Now, pheochromocytoma can be associated with your best friend called Men syndrome.
Men.
Can be associated with your best friend called
Converted.
neurofibromatosis. So it is my duty, I am bound to exclude these things because I am catching one thing. Clear? So
Yes, sir.
I am comfortable over here that I am dealing with likely pheochromocytoma, but I am incorporating this thing in my neurons that this is a case of secondary hypertension. I need to rule out everything on examination. But with this in my mind, I am going ahead and proceeding in this case. Hypertension completed. Let's go ahead. Second thing is long-standing history of decreased vision. Have you been diagnosed by any condition in the past? No. It means that you want to hide from me. Okay, go ahead and hide. I need to evaluate you. So I am seeing that your eye is bulging. Since how long it is bulging? It's the old story. Any problem with your vision? I am having blurring of the vision. First mistake, Dr. Sajjad, localize the symptoms. Both eyes,
Yes.
one eye. Whole field of the vision or a part of the field of the vision. And the patient is telling you that I am having problem only in my left eye. Blurring of the vision, no other symptoms. You want to ask about diplopia, you want to ask about any problem in the eyeball movement, go ahead and ask. But one thing is very sure that my patient is having positive finding of proptosis with decreased vision. Clear?
Yes, sir.
Two things. If there is proptosis in one eye, it is a must for us to rule out any growth, any tumor, any neoplasia, any new formation. But remember, it is usually outside the eyeball, which is pushing the eyeball in the front. Specifically, when you are dealing with unilateral proptosis. Are you with me?
Yes, sir.
It can be anything. Can be linked with orbit, can be linked with optic nerve, can be linked with the bones, can be linked with the soft tissue over there. But one thing I am registering in my mind that there is something fishy. Okay. If I am diagnosing the case up till now, and good candidate should diagnose it, a good thing. If not, no problem. We still have the history remaining. We still have our scheme remaining. Up till now, we are having hypertension, uncontrolled, with the tachycardia, with the tremors, with the sweating, with the flushing of the face, with the headache. Everything is episodic in the young male with proptosis of eyeball. Optic glioma. Not getting it, not reaching to it. No problem. Don't worry. Forget about that. Go back to your history skeleton. We are asking journal questions. In the journal questions, we are always asking first thing, weight changes. Any weight changes? Yes, I am having slight weight changes, 3 or 4 kilograms over 1 year. He's telling you. Then any fevers or high body temperatures? No. Any rash, spots, or pigmentation? Sajjad, you are asking me only rash. Please ask 3 questions. 3 questions. Rash will not cover everything. Rash, spots, or pigmentation. And if you're asking me this, I would say, yes, I am having pigmentation or spots. So this thing is coming in front of you. If you are telling me that you are having pigmentation, please show me right now. Immediately inspect the finding. Clear?
Yes, sir.
So this scaphoid spot, and it can be, you are very right, it can be tuberous sclerosis, it can be neurofibromatosis, but I am registering this thing in my neurons that there is one finding, one pigmentation. Any other such spots? Yes, I'm having multiple on my body. Okay, thank you. Then you asked me about lump. You asked me the question, any lump in your neck? I said no. This is not our scheme. Do you remember? We are
Yes,
always
sir.
asking any lumps and bumps anywhere in the body. Now you are bound to tell me that where are lumps and bumps, and you will show me that I am having lumps and bumps. Clear?
So actually, I want to explore men too. That's why.
Of course, it will, with the time, it will be getting excluded as we are taking the history.
Yes, sir.
Then again, pigmentation. Pigmentation. This is pigmentation. Sometimes patient is not telling you. Why? Because patient is not noticing it. Specifically in the cases of acanthosis nigricans. This is basically not acanthosis nigricans. This is freckles or freckling in the armpit, a part of neurofibromatosis. Clear?
Yes.
Then what are the other questions in the general questions? Joint pains, body aches, diet, appetite, sleep. Up till now, I am getting multiple findings, and I am in the middle of my history. I am summarizing this case for myself so that I should be comfortable exactly where my case is going. Number one, uncontrolled hypertension, tachycardia, flushes of the face, headache, tremors, sweatings, likely pheochromocytoma. With this pigmentation or freckling, with these lumps and bumps, with these scaphoid spots. If still I am confused about eye proptosis, I can correlate it now that this is a growth in the orbit, glioma. Clear?
Yes, sir.
So diagnosis is in your hand, that this is a case of uh, neurofibromatosis type 1 associated with pheochromocytoma. But the thing is that still we are missing a lot of stuff in this case. We need to avoid cross-questioning. How and why I'm telling you. Now, let's go back to our past history. Have you been diagnosed by any condition in the past? And he is saying that I have not been diagnosed and I was never went to any doctors. Okay, don't tell me. One thing, it's very important that this patient is having hypertension. Whenever you are dealing with hypertension, you must rule out complication of the hypertension, any history of stroke, any chest pain, any CKD, as evidenced by decrease or increase in waterworks, any foam in waterworks. It is a must for you that you should be very comfortable to ask about peripheral arterial disease, any pain on walking. As such, these much complications. Are you getting me?
Yes, sir.
Then, when there is uncontrolled hypertension, I will ask 2 or 3 questions only. Ever you got any altered sensorium, sleepiness, increased sleepiness, that is hypertensive install. Any sudden loss of vision, papilloedema, any renal shutdown, because I need to exclude hypertensive emergencies also in this patient in the past. Clear?
Yes, sir.
Reason. Reason is this word. This word. This word. This word is notorious. This is notorious. And this is notorious. Now, up till now, I am quite comfortable. I have ruled out all the other causes of secondary hypertension. I have ruled out hypertensive emergencies in the past. I am very sure that this is not white coat hypertension. Patient blood pressure is persistently high as given by RCP. And my patient is having underlying diagnosis of neurofibromatosis. Now step back and ask yourself if you are missing anything in the history in syndromic variety, because neurofibromatosis is a syndromic variety. Any fitting episode, any headache, any rapid weight loss, because they are prone to have multiple tumors also. Finish. Family history, present, can be present. It is autosomal dominant, but can be absent. Then social history, smoking, alcohol, job, illicit drug, driving, traveling, and then systemic inquiry if you are missing something. But we are doing our systemic inquiry side by side. Prasajad, is it clear?
Yes, sir.
Good. Now, let's plan our examination. How we will examine the patient. First of all, when we are starting examination, we are asking for observation charts, recent vitals. Then imagine what to do. Do not go blind. Do not go random. Plan yourself first. On the basis of history, I am very comfortable that I am dealing with pheochromocytoma associated with neurofibromatosis type 1. So I will tailor my examination according to that, but keeping in mind that I should be ruling out other causes of secondary hypertension also. Clear?
Yes, sir.
Let's start from hypertension. Check for sweating, check for tremors, check for pulse, check for visual acuity. Likely it will be normal because these features in pheochromocytoma are episodic. Bothered about acromegaly? No problem. C for frontal bossing, C for macroglossia, C for progonatism, C for increased interdental space, see the hands. Finish. Bothered about Cushing, C for hand, C for arms for paper thin skin, bruises, moon-shaped face, buffalo hump, stria on the tummy, finish. Bothered about fibrodysplasia, renal artery stenosis, put your stethoscope just, lateral to the umbilicus to listen to the bruit. Finish. So I am confirming my diagnosis by important negatives that I am dealing with pheochromocytoma. Clear?
Yes, sir.
Now what we are left with? We have done the complete examination of neurofibromatosis already. Still, you want me to show you? I can show you again. If anybody has just joined right now, so that you should be very comfortable. We are going ahead, and whenever there is a syndromic variety, we are always going head to toe, head to toe, head to toe, so that we should not miss anything. In the head, nothing. In the eyes, I am seeing proptosis. In the eyes, you want to go for fundoscopy, go ahead. Check for vision, offer vision testing. You were confused or you were thinking about tuberosclerosis, no issue. Open the patient mouth and look for high arch palate. Already, you have done the fundoscopy. This finding, Lynch nodules, they are usually visible on slit lamp examination. But when you are doing fundoscopy and you are putting a very sharp light in the eye, they are getting evident. Sometimes if they are quite crowded one, you can even see them with your simple torch. But chances are less. You can easily see them if you are doing fundoscopy. These are Lynch nodules, a part of a spectrum or a diagnostic criteria for neurofibromatosis type 1. Clear, Dr. Sajjad?
Yes, sir.
Please be with me. My voice is clear. Everything is clear because I'm not sure
Yes,
that
sir.
now.
Clear,
Yeah,
sir.
okay. So then I am coming down and I am seeing this cavillate spot and I'm asking the patient, do you have only one spot or multiple? He can show you. Still you are bothered about it. Can be tuberosclerosis. I'm not stopping you. Go to back, low back, sacral area, expose it. See the chagrin patches. That leathery rash. I'm sorry, I'm not having right now in the presentation because it's not a case of tuberosclerosis. Then these are freckles and they are usually present at two sites only, groin and armpit. The freckling, and this is also a part of diagnostic criteria for neurofibromatosis type. Clear?
Yes, sir.
Then I'm coming ahead. These are cutaneous or subcutaneous nodules, neurofibromas. Now, remember that there are two types of neurofibromas. One are simple, which you are seeing right now, very simple, very less potential as being malignant. They can be one or two, they can be multiple. So it is not must that the body should be filled with them. Then these are also same cutaneous neurofibromas. But there's a special type of neurofibroma which is called plexiform fibroma. Sorry, plexiform neurofibroma. This is dark in color, having pigmentation, and even sometimes there is hair growth on them, and they are having more malignant potential, and they have the potential to even dig out the bone. Clear?
Yes, sir.
Other than that, which I am not showing you that finding, is bony dysplasias. These patients can have, number one, increased skull size. Number two, short stature. Number three, bowing of the legs. And you people already know very well sphenoid dysplasia. So before we go ahead and we discuss this, the investigations for this case, let's recap this case. Let's see exactly what we can get in this case if it is there in front of us and what we should be suspecting or what should be, our approach in this case. Number one, remember that neurofibromatosis patient do have, number one, capillate spots. In the kids or children's before puberty, they are less than 5 millimeter. In the elderly, they are more than 15 millimeter. So pre-pubertal age, less than 5 millimeter. Post-pubertal age, it is 15 millimeter. Usually 6 or more. Then axillary or inguinal, both. Can be one, can be both. Axillary or inguinal freckles. Number three, you can get two, only two. I'm not saying body full of neurofibromas, only two or more neurofibromas. Again, they can be of two types. One I'm showing you like a skin color, other dark with hairs on them. These are plexiform neurofibromas which have the malignant potential. Usually, these patients of NF1 are not having brain tumors, schwannomas, but they love to have optic glioma. Optic glioma is a tumor of the sheath of the optic nerve which is protruding the eyeball outside. Other features I'm showing you, hamartomas, or you can say them hamartomas or Lynch nodules. Then a spectrum of orthopedic complications. I will say spectrum. Increased head size, sphenoidal dysplasias, facial dysplasias, bowing of the large bones. Along with that, your friend pheochromocytoma. Clear?
Yes, sir.
Good. We have done the history, completed the history, completed our examination. Now, how to investigate this patient. Investigation, again, we need to do two things. We are working on two fronts. One is uncontrolled hypertension, other is neurofibromatosis. Regarding uncontrolled hypertension in neurofibromatosis, it has two causes. Number one, pheochromocytoma. Number two, renal artery stenosis. And we need to exclude both. For pheochromocytoma, I am offering serum catecholamines, urinary catecholamines, urinary VMA, metanephrines. I'm very interested to offer abdominal imaging by MR scan to locate tumor. If not, I am going for MIBG scan. But I will never forget to offer the Doppler scan or MRA of the renal vessels. Why? Because in neurofibromatosis, uncontrolled hypertension can be because of pheochromocytoma as well as fibrodysplasia renal artery stenosis. Clear?
Yes, sir.
If you are thinking that there is something else, like you were bothered about Cohen syndrome, so initial workup you can offer potassium also or electrolytes also. Getting back to the primary diagnosis, that is right now the pain in our neck that the patient is not expressing, rather we need to diagnose it, and we need to be a holistic approach in this case, is that we are investigating this patient like it is presenting first day in the hospital. Might be some workup has been done before, but it is hidden from us. So we will be investigating it from the start. So what to do now? Number one, remember that the mainstay is two genes. NF1 gene on chromosome 17, and the second gene is mental block. I think spread gene. So two genes, NF1 gene and spread gene. There is a protein, neurofibromin, which is being produced by NF1 gene, which is a tumor suppressor protein. And when this protein is deficient, patient is at the risk of multiple tumors. Clear?
Yes, sir.
Good. Second thing, these patients can have plexiform neurofibromas. And I was telling you that they have malignant potential. They can even erode the bone. They can even go deeper in the soft tissue. So you need to be deliberate in offering MR scan, CT scan, or MR scan. Bowing of the legs or any changes in the skeleton, of course, the first one should be simple X-ray. Regarding this tumor in the eye, that is glioma, I need to go for visual potential, OCT. I want MRI of the orbit, and of course, I need to take the consultation of ophthalmologist and this neurosurgeon. If diagnosis is still in confusion, I can take the biopsy of neurofibromas. But the thing is that this patient is having uncontrolled hypertension. I will never forget to offer the baseline testing for that also: fasting lipid profile, renal function test, urinary electrolytes, serum electrolytes, and echocardiography. So I am holistically telling the investigations to my examiner. Coming back to the management. Again, we are dividing our case when we are managing the case under 3 headings. We are never in hurry for surgery. We are never in hurry for any drug management. We are dividing our case under 3 headings, non-pharmacological, pharmacological, surgical/endoscopic management. Non-pharmacological, patient education, patient counseling, telling him that about the disease nature, telling him that we need to follow him on yearly basis. We need to follow even the head circumference if it is increasing. We need to follow the tumors if they are present. We need to offer MR scans. And this follow-up will be very holistic, not only the neurosurgeon, neurologist will follow, other ophthalmologist, other dermatologist, even orthopedician will follow this patient on a yearly basis. We should be thinking about family screening. We should be counseling the patient, offering genetic counseling to the patient that this is an autosomal dominant disease. We need to educate about the complications of hypertension. Clear, Dr. Sajjad?
Yes, sir.
Are you with me?
Yes.
Any problem in voice?
Slide, sir, is fine.
Okay. Ultimately, now next step is to go ahead and manage the patient pharmacologically. Pharmacologically, you are telling nicely alpha blockers, beta blockers, ultimately is the surgical resection. Regarding management of neurofibromatosis, we are doing the surgeries only for 2 reasons. If there is any malignant potential of any neurofibroma, especially plexiform, or cosmetic reason, or there is any compression effect, like you're seeing that in this patient. The patient is having glioma. Are you getting me?
Yes, sir.
Now, sometimes these patients do present with the itching also, a non-specific complaint on these neurofibromas. So antihistamine can be offered. There's a newer medication being offered in the cases of neurofibromatosis type 1, and it is called selumetinib, and this is, I think, biologic. Selumetinib, this is biologic, and this is doing something with the ROS pathway. This is a newer medication for neurofibromatosis. Any questions, any queries, any confusions, any problems? Anybody wants to ask anything, please go ahead, use the raise hand option to come forward. So the message over here is that we need, number one, to check what is the cause of secondary hypertension. Number two, what are the complications of this hypertension? Number three, to rule out any hypertensive emergencies in the past and destruction caused by them. Number four, what is the underlying diagnosis, the primary diagnosis, that is neurofibromatosis type 1. This was indeed a difficult case, but yes, Dr. Sajjad has done his level best and is coming closer to diagnosis. And of course, these cases are slightly, you can say, challenging, in which you should be on your toes and you should plan your history and the examination quite accurately. Dr. Cameron, please unmute.
Assalamualaikum, sir. Thank you for the
Walaikum
nice
assalam.
case. Sir, it is regarding the investigation, as neurofibromatosis is a clinical diagnosis. So, do
Yes.
we need to do genetic testing?
Yes, of course, I'm telling you.
Yeah.
Yes. NF1 gene, spread gene. Here I am slightly confused. If anybody can correct me, I think this is a spread gene. Second gene is spread gene, not coming in my mind. One is NF1, I am very sure. But second gene is, I think the name is spread gene, if I am not wrong.
Thank you, sir.
Okay. Dr. Sajjad, are you ready for your second case?
Yes, sir.
Good. Dr. Sajjad, are you ready?
Yes, sir. Please.
Okay. Please give me a second. Dr. Sajjad, this is the case. Please take your time, prepare it well, then get back to me.
Okay, sir.
So Dr. Sajjad, are you ready
Yes, sir.
or you need more time?
Yes, sir. It's fine.
Okay, Dr. Sajjad, just a second, please. Let me set a timer for you. So total 10 minutes according to RCP protocol, and I will prompt you at 8 minutes. And your time starts now.
Hello, I'm Dr. Rahman, one of the doctor in the clinic today. May I confirm
Mhm.
that you're Mr. Jidan, 60 years age?
I am Mr. Zaidan and I am 60 years of age.
Okay. Today I'm here to discuss about your health condition as well as I'll address your concern. Is it all right?
Fully all right.
Okay. Before going to full discussion, may I know how much you know about your health condition?
I am suffering for about last 2 or 3 months. I am having night sweats, fevers. I am having weight loss. Also, I don't like to eat much. And with these lumps and bumps, they are quite disturbing. So I want to know exactly what's wrong with me.
Okay, Mr. Jidan, I'm really sorry for that. You are suffering from this problem.
Mm-hmm,
Uh, you are suffering actually for this problem. You are
mm-hmm,
suffering from a problem that is not as you expected.
mm-hmm.
So our medical team has decided that, and after some investigation, that you are suffering from a cancer, and it's a cancer of the lymph gland. We called it lymphoma.
That's a bad news. So is it curable?
I appreciate your concern that before going to for this comment, first of all, we have to fully diagnose about your condition, whether in which stage you are in, and then I will be in better position whether it is curable or not. Are you getting me?
I'm getting you.
Okay, so for your complaint, what we have done so far, that we have formed a multidisciplinary team which comprise the cancer doctor and
Mm-hmm,
as well as the um, Macmillan nurse and as well
mm-hmm,
as the the occupational therapist and
mm-hmm,
social healthcare worker.
mm-hmm.
So our multidisciplinary team had decided that to know the exact stage of your disease, we have to go for another test, and it is the PET scan. Do you have any
Mm-hmm.
idea about that?
No idea about that.
Okay, so in this, it's a special type of, that scan, and that's by this procedure, that by this test, we will be in better position in which stage your disease is on. Are you getting me?
I'm getting you, but I have listened about something called CT scan. I have listened about other type of testing, but I'm not sure about PET scan. Exactly what they are looking in the PET scan.
Actually, it is advanced, more advanced form of, that scan technique, and it's more advanced than the CT scan, as you heard, and as well as MRI scan, and it exactly look at in which location your tumor is present or not. Are you getting me?
I'm getting you. Exactly
Uh,
which sort of tumor is that? And I'm really worried that what are the options for its treatment? And do you think that there is any hope present?
I appreciate your concern. And first of all, your tumor is the tumor of gland. There is different type of gland in our body, and one of the gland we call it lymph node, and your tumor is affecting the lymph gland, and we called
Mm-hmm,
it lymphoma. and
Mhm.
and there is a very good treatment option for this. And if your disease is diagnosed in early stage, then
Mhm.
there is possibility of curable, and many people lead almost normal life with this treatment. Are you with me?
That's a good thing. I think this is a good news for me. So, how you will cure it? What are the options available? Like, is there any option for surgery to remove it?
I appreciate your concern. For the specific definitive management plan, first of all, we have to go for this scan. Then we will be in better position in the treatment option. Are you getting me? And
I'm
first of
getting
all,
you.
okay. So first of all, for this investigation, I mean the scan, will we have will take consent from you, and then you come to us, and then it will put you in a special machine, and just like a CT scan machine, and then
Mhm.
and we will identify the exact location of the tumor in your body. Uh, are you with me?
I'm with you. So basically, you want to say that you will be planning the treatment after this scanning. I'm sorry, I'm forgetting the name of the scan. I'm not a medical
It's
personnel.
PACES scan. Okay.
Okay, so I want to know if this is an early stage. So what are the options? Is there any
Okay.
option which you can remove it through surgery?
I appreciate your concern. There is different type of treatment modalities, and one of the modalities is special medicine. Will give you through the blood channels, and it's called chemotherapy. And there is a very good response for for this kind of tumor with this medication. And another option is sometime the radiotherapy is also can be given, but everything will be depend on the multidisciplinary team, and after getting your complete diagnosis and stage by going for PET scan. Are you getting me?
I'm getting you.
Okay. If we will not we cannot if we cannot go for the PET scan, then we will not be in better position where whether your disease is in which stage. And I'm afraid to tell you that, and sometimes it's happened that but diagnosis may delay, and as well as it will be in advanced condition. I'm afraid to tell you that.
No, of course, I will never refuse any scanning which you're offering to me, and I'm quite concerned about my condition also. But can you please tell me that is there any chances that this condition is running in the family?
But actually, it's not running in the family, but the family member have more chance of having this disease. I'm afraid to tell you that.
Secondly, of course, being a patient, and when you are telling to a patient about a diagnosis of a cancer, when we are talking, we are thinking about the cancer in the media talks, it means that this is the end of life. So, what are the chances that, say, for example, if I am getting at the curative treatment at the early age, what are the chances for cure, or you can say for survival?
I appreciate your concern. Yes, but as if it's diagnosed in early, and with chemotherapy, special medicine, and there is more chances of cure. And many people lives almost completely normal life with this.
1 minute and 30 seconds.
Okay. So may I know that what do you do for your living?
I am a laborer.
Okay. And is this problem affecting your daily life as well as job life?
Really it is impacting. Like I'm having no energy at all.
Okay. So what will do for you? I will involve the social health care worker as well as occupational health physician, and they will help you in this regard. Do you smoke?
Ah, yeah, I do smoke.
How many cigarettes for how long?
Almost 20 sticks per day for last 5 years.
Okay, smoking is injurious for health. I advise you to stop smoking, and I'll refer you to smoking cessation clinic. Are you financially supported?
No, I am a sole breadwinner for my family.
Okay, I will help you in this regard. I will involve the social healthcare worker in this regard. Who take care of you in home? Do you need any social help?
No, I am living with my wife.
Okay, so do you have any concerns so far?
No concerns, just I am worried about that it should start as early as possible because I was never suspecting it and I
Okay,
was not
so
thinking that it will come out to be a cancer.
appreciate your concern. Yes, as you wish to going for this test,
Time
and
is up.
okay,
Please give me a minute and I'm getting back to you. Okay, let's get back to our discussion. Dr. Sajjad, let's explore this scenario and let's see exactly how we can make it more better. But overall, your performance was good in this case, and you are having a good grip on the case. Okay, but yes, there are few slight mistakes which need to get rectified. Now, voice is clear and loud to you people.
yes, clear.
Good, amazing. See that this patient is 60 years of age, presented with night sweats, anorexia, unexplained weight loss, fatigue, lymphadenopathy, XEN biopsy has already been done, which is revealing Hodgkin lymphoma. Our plan is to do PET scan to accurate stage the tumor and the task. Now read the task, please, carefully with me. Okay? Your task is to completely explain the diagnosis to the patient, number one. Number two, guide him regarding available treatment options. Number three, lifestyle modifications pertinent to his diagnosis. Are you with me?
Yes, sir.
You are stressing more on the PET scan. Your stress was there. It is a part of our plan, Dr. Sajjad. It is not a part of our task. I am not saying that we will not tell this to the patient. I am not saying that we will not explain to the patient. But I am saying that we will get marks when we are completing three things in the task: explanation of diagnosis, telling about treatment, lifestyle modifications. Clear?
Yes, sir.
Now, sometime RCP is giving you the treatment options that you have to counsel. Say, for example, for chemotherapy, for radiotherapy, sometimes they are writing it like a journal option that you should be knowing exactly what are the treatment options available for Hodgkin lymphoma. This scenario is relatively a scenario in which you have to break the bad news. This is a scenario in which patient is not aware exactly that what is coming ahead. The best way to deal with this scenario is that, hello sir, good morning. My name is Dr. Assam, one of the doctor in the clinic today. Am I speaking with Mr. Zidan, 60 years of age? Yes, I am. Sir, I hope you are quite comfortable with me today. And we are over here to discuss about your health condition and its management. Introduction, establishing the rapport, setting the agenda, then offer. Offer do you need anybody else in this room, like your friends or family, for your sport? Fifth, idea. ICE. I for idea. What you have been told so far, and he is telling you the symptoms. Am I right?
Yes, sir.
Nowhere he is telling you that I am having cancer. You are being observed. Your each and every action is being noted over there. Patient is not aware of the cancer diagnosis. He is simply telling you the symptoms. I for idea. Idea shows that he is having no idea about the cancer diagnosis. C for concerns. Do you have any expectations or concerns from today's meeting? Yes or no, he will tell you. E for explanation. Sir, I appreciate your knowledge that you are knowing quite fully about your health condition, that you are having these, and these symptoms. But we have done or taken the snip of your gland, and the report is with me today. Sir, I'm sorry, I don't have a good news for you. Sir, I'm sorry, I am the one who is breaking this bad news. So, two warning shots, at least two warning shots with the pauses. Clear?
Yes, sir.
You're making him ready for something which is coming ahead. He will not directly say that you're having a cancer, you're having a lymphoma, or something like that. So, how to break? So, the report is with me, and it is not as we hoped for. I'm sorry, I'm the one who is breaking this bad news today. Report shows that you are having a cancer called Hodgkin lymphoma, which is the cancer of blood cells. Golden silence. Let him express. Offer tissue paper. Offer glass of water. Empathy. Sympathy. Say that we are with you in these difficult times, and we will not let you suffer. This is not something uncommon. And in lot of times, this cancer is almost curable. Clear?
Yes.
Our team is taking it quite seriously. And in this regard, we are planning a specialized scan called PET scan. Don't bother by the medical term. This is a scan in which we are looking for active cancer cells in the whole body. Finish. I will not speak more than that on the PET scan. Clear?
Yes, sir.
Because I know my task is quite lengthy. I need to talk on three things. After this scan, when we are knowing that exactly at which area they are viable tumor cells, we will plan the treatment. Now explain why the patient can get this Hodgkin lymphoma. So there are multiple causes, and sometimes the cause is not known. Some patients are getting it because of some medication which they are taking to suppress their defense system. Sometimes it is happening because of some virus infection. This cancer is spreading in the glands, which can lead to all the symptoms which you are having. This cancer is having a good prognosis if it is treated adequately, and the good options are chemotherapy followed by radiotherapy. But again, the staging of the tumor, its extent matters a lot. That's why we are in a hurry to plan the scan as early as possible. So two things you're mentioning over there, chemotherapy followed by radiotherapy. And you are negating the surgery of the tumor, except in some unwanted circumstances like demulking or something like that. So no role for surgery. Are you getting me?
Yes, sir.
Good. We will make sure that your cancer get treated fully. And let me tell you a good news that almost 8 out of 10 patients survive with the treatment after 5 years. Not only these treatment options, but also we will make sure that we are making good referral to the dietitian, the physiotherapy team, so that you should have an active lifestyle with good dietitian. We have a specialized nurses and the teams and the mood doctors which are taking care of such patients in this condition. After that, you have to ask exactly the social support, and he's telling you that the wife is taking care. How is the health of the wife? If the health of the wife is compromised, you are supposed to provide social support also. What he's doing, he is a laborer. So you have to offer the support not only by the occupational health physician, but also by occupational health therapist to even make the changes there. Then, of course, how many dependents are there? And if there is any compromise in financial or social support, you need to provide through social teams. Clear?
Yes, sir.
In the end, what you have to do, if you have the time, you will say to patient that, can you please recap for me? Because in clinical communication, patient is recapping. If he is missing something, you will add it. Clear?
Yes, sir.
Any questions, any queries? Any problems, any issues?
Sir, we say cancer of blood or cancer of gland, sir?
Um, Basically, it is very difficult to explain in the English because there's everything is going on with the B cells and all that stuff. So I
Okay,
think both are correct. You can say that this is a type of the cancer which is dealing with the blood cells residing in the glands of the body, something like that.
okay, sir.
Because you can't explain everything with a simple English. Something is quite difficult to explain. But you should be giving this message quite clearly to the patient that you are having cancer and we are having this plan, and we will go on to our plan in this fashion, and we will provide you all the support in all the possible ways. One thing you are making mistake over there, Macmillan nurses are usually for palliative care.
Exactly, sir.
We are not starting palliative care, so you should not offer it. Yes, you can say specialized nurses, cancer nurses. Hidden agendas, nutrition of the patient, hidden agenda, job of the patient, hidden agenda, patient family support, dependents, everything should be explained and should be addressed. Any other questions? Anybody wants to ask any question? Okay, if no more questions, we are concluding our session. Have a good night. Enjoy your weekend and goodbye.
Thank you, sir.